Good morning, ladies and gentlemen, and thank you for waiting. Welcome to the Completing the QAPI Self-Assessment call. Please note that all lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Christy Wergen. Ms. Wergen, the floor is yours.
Thank you very much, and good morning, everyone. This is Christy Wergen. I can't even say my name right after that. With Stratus Health, we're the Minnesota organization that's part of the Lake Superior Quality Innovation Network, or LSQIN. We represent Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Quality Improvement Organization program. So I'd like to welcome you all to this educational session this morning, and this is a working webinar entitled Completing the QAPI Self-Assessment, so I hope you're all ready to do some work with your teams. We're very privileged to have Dr. Jane Pederson facilitate this working session today, and Dr. Pederson is the Chief Medical Officer here at Stratus Health, and she helped create the QAPI Self-Assessment tool. So thank you very much, Jane. Let's go ahead and get started.
Hi, everybody. Thanks for joining us this morning. Hopefully you've all got a copy of your self-assessment in front of you to work on with your teams. How this is going to work this morning is this is really, truly, like Christy said, a working webinar, meaning we're all sitting down together and filling out the QAPI self-assessment tool. So I'm going to read through each of the questions quickly, give you a little kind of helpful hints on maybe what not started would look like, on your way, doing great would look like, give you a few minutes for your team to discuss and answer, and then we'll move on to the next question. You'll notice that there's also a chat function up on the screen. We encourage you to put any questions that you're having as you're going along into chat, and we will try to answer them as they come up. I'm not sure if we'll have a lot of time at the end for discussion, but we'll work towards that in case anyone has any other questions that they'd like to ask. So let's go ahead and get started. Let's start with question. There we go. We got to get our slides ahead here. One of the things I just want to remind everyone, the reason we're doing this as a team is really the self-assessment tool is meant to be something that's done as a team, not meant to be something that's just done by one person and completed and put in a folder, because it actually is something that's supposed to help your team decide where you want to focus, what maybe is going well in your organization in regard to QAPI, and what are some of the things that you may want to work on. Just as a reminder, there's 5 elements of QAPI, is design and scope, the governance and leadership, feedback, data sharing and monitoring, performance improvement projects, and systemic analysis and systematic action. The tool is not specifically designed as that, although many of you may have one of the tools that I believe Michigan reordered into those elements. So there is another option, another version out there. Okay, now we'll get going with the questions. So the first one, our organization has developed principles guiding how QAPI will be incorporated into our culture and built into how we do our work. For example, we can say that QAPI is a method for approaching decision-making and problem-solving rather than considered a separate program. So when I look at this one, I would say that not started is really, we kind of rely on our gut to tell us what we're going to do for our quality work. We know our organization pretty well. We don't need tools or anything like that to help us. On our way would be, you're using some of the tools. We're weighing decisions maybe against goals. We've developed a few metrics. But really doing great is when you're starting to use the QAPI tools as really second nature, that you're well-versed in how to do a cause and effect diagram, do flow charts, use your prioritization matrix to make decisions. So those just become part of how you do your work, and you don't even think about it. It's just you wouldn't think of not doing it that way. So I'll give you a couple minutes to think about where you are in relation to that. Or I should say a couple minutes.
a reminder, if when you're having your discussions, if anyone has any questions, please just put those in chat so we can address those.
Okay, let's go on to the next question. Our organization has identified how all service lines and departments will utilize and be engaged in QAPI to plan and do their work. For example, we can say that all service lines and departments use data to make decisions and drive improvements, and use measurement to determine if improvement efforts were successful. So again, I would say, in that not started, again, we kind of rely on our gut. Maybe each of the service lines and departments are doing work, but they're not necessarily using any data that they know what needs to be improved. We just base it on how well we know our organization. On our way would be, they do use some data, maybe collect a few measures. And then doing great would be, really all the departments can come to meetings and they may have run charts or even control charts that say, hey, this is what we're working on, here's how our performance looks, here's what we've done for the last 6 months. So again, those metrics are really built into how they're doing their work within each of your departments or service lines. Okay, let's move on to our next one. Our organization has developed a written QAPI plan that contains the steps that the organization takes to identify, implement, and sustain continuous improvements in all departments, and is revised on an ongoing basis. So, for example, a written plan that is done purely for compliance and not referenced would not meet the intent of a QAPI plan. So again, that not started, I'd say, if you got a pre-populated plan from your corporation or that you shared with other facilities that you put your name on and put up on the shelf, that would be, I think, a not started. Somewhere in the middle would be, your team sat down, you maybe put some comments specific to your organization, but they're fairly generic. You wouldn't necessarily get a flavor for your organization or how you're different than another organization. I'd say really the doing great would be your QAPI plan is really something that you turn to, that you say this is a useful document that contains information that I now know where to find. Maybe some useful references for different areas, different tools and things that you find useful, things like that. So it's actually something that you're using, and when a team finds something that they thought was really valuable, they say, hey, we should have that in the QAPI plan so other people can access it. It's probably even electronically available as opposed to just sitting in a paper copy someplace. One of the things I didn't mention at the beginning, too, with this webinar and rating yourself is keep in mind, there's no one, this isn't something that you're going to be graded on. And I think we all feel bad if we say, gosh, we're not at the, doing great on everything. I thought we were doing so well in our quality work. I think that's something that this self-assessment is meant to point out that we all have opportunities for improvement. And, really, there probably aren't that many areas where everyone's doing great because we all have opportunity for improvement. So you'll probably find places where you're, maybe closer to that not started, maybe somewhere in the middle, and maybe a few places where you're getting close to the doing great. So, rate yourself honestly because that gives you something to then work on going forward. Okay, let's go on to the next one. Our board of directors and trustees, if applicable, are engaged in and supportive of the performance improvement work being done in our organization. For example, it would be evident from meeting minutes of the board or other leadership meetings that they are informed of what is being learned from the data, and they provide input on what initiatives should be considered. Other examples would be having leadership, board or executive leadership, representation on performance improvement projects or teams, and providing resources to support QAPI. So in this one, I'd say really the not started is if, quality improvement is still really the job of one person. You have someone who's kind of in charge of quality, and that's their job, and they lead it, and kind of other people maybe support them, but really quality's their baby. The middle, I'd say, it's something that we talk about that's on the agenda at leadership meetings. Just kind of where are we, kind of that report out type of agenda or that reporting out, but not necessarily getting involved or putting input in, but just to report out. And then that really doing great would be, your board may actually have a quality team as part of the board membership that actually is intended to be able to either provide support, to work with your teams doing quality. The board's actually using quality improvement tools. Maybe the board members are weighing in on your prioritization. Maybe that's something you do as the board because they have another view of how you prioritize improvement work within your organization. So they're really much more, your leadership is much more actively engaged in quality and has a vested interest in having quality be successful in your organization. Okay. The next one, QAPI is considered a priority in our organization. For example, there's a process of covering care groupers who are asked to spend time on improvement teams. This one is one where you see homes that aren't really at this point are often the ones that, okay, if something bad happens or we get a bad survey, we can't be working on quality stuff right now. We've got to shift our attention away. So it's not we don't use quality as how to solve that problem. Quality is something that we do when we have time to do it, but if there's fires to put out, we put out the fires and we work on quality improvement later. So on our way would be, we are doing quality improvement work. We have multidisciplinary teams. CNAs are able to be on teams, but we don't really have a good way to have coverage for them. So a lot of times they're feeling kind of stressed. They're torn between if they should go to this team meeting. Their peers are probably going to be kind of frustrated with them because they've had to pick up slack when they've been at this meeting, and so that's not built into the workflow. Where doing great would look is that this was just part of what everybody does. You found some creative ways to build this into the workday. For example, nursing assistants are all going to be participating in some type of quality work at some point, and so they realize that, each one of them, it's not just one person and everybody else has to cover for them, but each of them will be in that role, and so it's just part of the role of being a nursing assistant in that organization is that also you're going to be working on some quality work, and so it's and you've worked that into the workflow, so people aren't feeling that that's something on top of what they have to do that day. So this is kind of a big one. So the next one, a QAPI is an integral component of new caregiver orientation and training. For example, new caregivers understand and can describe their role in identifying opportunities for improvement. Another example is that new caregivers expect that they will be active participants on improvement teams. So I'd say not started would be someone coming new into your organization is given a variety of policies or procedures around quality to review, and that they should understand this is what we do. On your way would be during orientation, you talk about your QAPI strategy or plan, that this is something we're doing, we're working on QAPI, this is how our staff are involved. I'd say doing great would be part of orientation is for a new employee to actually jump right into a current performance improvement project. So that's part of just their orientation would be, and then you'll be working with this team and you'll start on that right from the get-go. So that's something that is equally important to everything else that they need to learn about your organization, and they would just jump right in as a participant and a way to really learn by doing about your QAPI work. Next one, training is available to all caregivers on performance improvement strategies and tools. So not started would be there really isn't special training on quality improvement strategies and tools in your organization. On our way would be, maybe you do have some in-services where staff get together to learn about things and maybe do some discussion. So there's just an awareness building. But then really doing great would be any performance improvement project, teaching really becomes part of it. So it's not only a way for people to be part of a project, but you look at it as a way to really educate staff, and that's part of the reason to bring new staff into performance improvement projects, because you're actively teaching them how to use tools, and so they learn really by doing as well as hearing about these things and that they're important to your organization. The next one, when conducting performance improvement projects, we make a small change and measure the effect of that change before implementing more broadly. An example of a small change is pilot testing and measuring with one nurse, one resident, on one day or one unit, and then expanding the testing based on those results. So again, not started would be some change comes down, it's determined either by the quality committee or by leadership, and then it's implemented. On our way would be, yeah, we occasionally pilot test it, maybe give it a try in one unit, but at most still, we mainly will roll things out pretty quickly. There won't be a lot of pilot testing done. And then doing great would be, we always do that N of one test where we try it with one person, one resident. We learn from it. We do that and then we slowly expand that so that we're ready to roll our change out more broadly. And so then that also gets into some measurement too. In order to do that, you're obviously measuring those changes along with it, which is going to link to some of the other questions later as well. This question always reminds me of my kid's piano teacher, when she always says, slow practice makes fast progress. I really think that's the key with the N of one. It may seem slow, but your progress will be much faster in the long run. Next one, when addressing performance improvement opportunities, our organization focuses on making changes to systems and processes rather than focusing on individual behaviors. For example, we avoid assuming that education or training of an individual is the problem. Instead, we focus on what was going on at the time that allowed a problem to occur and look for opportunities to change the process in order to minimize the chance of the problem recurring. So again, the not started would be, we see what happened. We assume that people need to be more careful, they need to be educated, they need to be trained, and that's the primary approach that we use. On our way would be, we do some root cause analysis, we maybe identify some other things that were happening, but probably still doing education and training as a mainstay of our intervention, along with some other things. And then really doing great would be, we're really only using education and training occasionally and as an adjunct to something that we're implementing that's totally new that people don't already know about. You'll actually see this theme come back in a couple other questions later in the assessment as well.
So it looks like we have a question from Bev. When you talked about an N of one, and with your example from your children, piano teacher, it would be fair to say slow and steady wins the race, correct?
Yes.
Yeah.
That's another good way of saying it.
I like that.
Okay, let's go to the next one. Our organization has established a culture in which caregivers are held accountable for their performance, but not punished for errors and do not fear retaliation for reporting quality concerns. For example, we have a process in place to distinguish between unintentional errors and intentional reckless behavior, and only the latter is addressed through disciplinary actions. This one is based a lot on those principles of just culture, where you can manage behaviors and manage systems. And you find that many times managing behaviors really requires managing the process. And so for this, not started would be in your organization to hold accountable means really equates with if you're not accountable for actions, you'll receive discipline. You'll find out who is responsible, and that person will be disciplined. They'll be held accountable by way of discipline. On our way would start to realize that, it's the system that broke down in many cases, but there may still be some elements of, we still need to discipline people to make sure that people know that they're going to be held accountable for, good performance. There's that kind of, we want to move into saying, processes account for a lot, but we're really afraid that people, if we say, processes drive everything, well, then our staff they're going to say, I have nothing to do with it, then it's all the process. So kind of on the way, you're kind of recognizing that, you're kind of caught in that middle. But really doing great is where you really do have a culture where you have implemented a algorithm, whether it's a just culture algorithm, that helps you sort through, okay, how do I determine was this intentional reckless behavior, which happens actually quite rarely and should be disciplined, versus actions that happened because of the process or the situation that was in place, that if I don't change that process or system, those same actions are going to happen again, whether it be this person or another person. No matter if we have discipline, they're still going to occur because people are feeling the need to do this in order to get their job done. The next one, leadership can clearly describe to someone unfamiliar with the organization our approach to QAPI and give accurate and up-to-date examples of how the facility is using QAPI to improve quality and safety of resident care. For example, the administrator can clearly describe the current performance improvement initiatives or projects and how the work is guided by caregivers involved in the topic, as well as input from residents and families. So I'd say the not started would be, again, QI is, in QA meetings, are a report out. Here's what our fall rate was, here's what our pressure ulcer rate is, and people come with what they need to report, and that's their purpose for being at the meeting, and once those reports are reported out, we're done. Maybe people ask a few questions. On the other side would be that doing great would be, we really have, it's very visible where our goals are, and we've set those goals with some data and measurement in our mind, and the administrator out talking to other organizations could clearly describe, this is what our goal is, this is where we're at, this is what we're doing to address that, that's why we're doing to address that, and this is where we think we can get to by such and such a time. So really being able to kind of go that whole spectrum. On our way, maybe, someplace in between our QA meetings, we've gone beyond the reporting out, but we really aren't still at that point of, really looking at, how do we know where we're going to be 3 months from now? We're looking at our data retrospectively, but we're not necessarily saying, okay, I think we can get to here because of such and such and such. Here's what we're going to do to get here. Here's how we're going to know if we're going to get there. The next one. Our organization has identified all of our sources of data and information relevant to our organization to use for QAPI. This includes data that reflects measures of clinical care, input from caregivers, residents, families, and stakeholders, and other data that reflects the services provided by our organization. For example, we have listed all available measures, indicators, or sources of data and carefully selected those that are relevant to our organization that we will use for decision-making. Likewise, we've excluded measures that are not currently relevant and that we are not actively using in our decision-making process. So not started would be, we just track all of the, publicly reported measures, and that's what we look at because that's what's out there and those are what we have to pay attention to. On our way would be, we kind of have a mix. We're kind of tracking all those things, and then maybe we have some measures that we're doing either because our corporation has those measures or maybe we've selected a measure or two for ourselves. And then doing great would really be saying, okay, we're aware of all the externally reported measures. We understand and decided which ones are most relevant to our organization or we think that we can have an impact on, and we're actively monitoring those. But for most of our improvement work, we're actually generating our own data because we can get it in real time and actually look at our performance much quicker than we can for any of the externally reported measures. The next one, for the relevant sources of data we identify, our organization sets targets or goals for desired performance, as well as thresholds for minimum performance. For example, our goal for resident ratings for recommending our facility to family and friends is 100%, and our threshold is 85%, meaning we will revise the strategy we are using to reach our goal if we fall below this level. So, example I like to use for this one is, if not started would be, you're just assuming there's some measures you can't actually move. Food always comes up because that's always one of those big measures on satisfaction surveys. And I hear organizations say, well, that's not something we can move because we just can't please everybody. There's no way you can please everybody on food. Well, if you're going to measure it and you think it's important and it's something important to your residents, you have to take that and set your goals and set your thresholds and really move to do that. Those measures mean something and you have to take it seriously. So not started would be just making that assumption that you can't move those. On our way would be, we got to measure. It's not really improving, but let's keep measuring it a bit longer because maybe something will get better. That's not you don't have a threshold in place that really says, okay, sorry, time out here. Measuring never makes a change. Measuring just measures. And so we can measure till the cows come home and we probably still won't have an improvement here. Doing great is really using that threshold and saying, yep, okay, we hit that. We are not making it to this level we wanted to. Obviously, our approach isn't it isn't working. We need to go back to the drawing board and actually go back to the drawing board and make a change in what you're doing. The next one, we have a system to effectively collect, analyze, and display our data to identify opportunities for our organization to make improvements. This includes comparing the results of the data to benchmarks or to our internal performance targets or goals. For example, performance improvement projects or initiatives are selected based on facility performance as compared to national benchmarks, identified best practice, or applicable clinical guidelines. So I'd say not started is you kind of just look at your data month to month and whether or not you were better or worse than the month before. On our way would be really, having some run charts. You're looking over time. You've decided those things that are important to monitor over time. You're looking at it. You're analyzing them. Doing great would actually be applying what we call some statistical process control techniques. where you're actually able to interpret your run charts and determine if change has actually been made. One of the mistakes we often make in quality improvement is we don't use the analytics that go along with run charts to determine have we really made a difference, or is what we're really seeing in our run chart just part of the variation that's built into our current process. So doing great would be really understanding that variation within your current process and therefore being able to look at your results and determine if you actually made a change to the underlying process and we're seeing true improvement. The next one, our organization has or supports the development of employees who have skill in analyzing and interpreting data to assess their performance and support improvement initiatives. For example, our organization provides opportunities for training and education on data collection and measurement methodology to caregivers involved in QAPI. This is a challenging one, I think, for any clinical organizations because most of the people that come into working in long-term and post-acute care don't come from an analytic background. And so having to develop that within an organization can be challenging. So it's not started really is you don't have anyone that this is an area of interest or that this is an area that is kind of an expectation or that you've recruited someone to your organization that really understands some of this analytic work. Maybe on your way would be you do have somebody that has some interest, or maybe even you've found a way to get that through another organization. Maybe you've tapped into your trade association or a consultant to help you with that. And then on our way or doing great would really be this is a core competency. You've got people in your organization and you've actually recruited for people that are good at this analytic piece of the quality side to really help you with QAPI so that you know when you've made a change and when that change is represents a real change versus just variation in your current process. The next one, from our identified opportunities for improvement, we have a systematic and objective way to prioritize the opportunities in order to determine what we will work on. This process takes in consideration input from multiple disciplines, residents, and families. This process identifies problems that pose a high risk to residents and caregivers, is frequent in nature, or otherwise impact the safety and quality of life of residents. So that not started end would be, gosh, we know our organization so well. We know what we need to work on. We don't need help with any kind of prioritization matrix. We trust our gut here. On our way would be, we actually have a discussion to look at these various options, but we don't use an objective tool. But we do discuss, based on what we think is most important and relevant to our residents. And then doing great would really be, we do have criteria, and we use those criteria, and we bring in people from different perspectives to actually weigh in on it to make sure that we're picking opportunities that really are the most relevant, that we can accomplish, that will really make the biggest difference for our organization, even if maybe they're the ones that are going to require a little bit more work. When a performance improvement opportunity is identified as a priority, we have a process in place to charter a project. This charter describes the scope and objectives of the project so the team working on it has a clear understanding of what they are being asked to accomplish. So again, not started would basically, we don't need charters, we don't use them, they're just too much work, we know what we need to do, that's not a useful tool. The on our way would be, you do give your performance improvement teams some guidance, but it's not necessarily in the form of a charter. It's maybe a description of what you're doing, some general guidance. And then the doing great would be charters are just routine. It's how you set up your projects. It just becomes a knee-jerk way of doing any kind of performance improvement work, is to think about, okay, let's work through what we would put in the charter for this, so the team really has that as that structure. Next one, for our performance improvement projects, we have a process in place for documenting what we have done, including highlights, progress, and lessons learned. For example, we have project documentation templates that are consistently used and filed electronically in a standardized fashion for future reference. This is one of those struggles, is to try to keep things over time. And so, as many organizations, I put the not started in, each person may have a folder of their notes. Maybe the leader has a folder someplace that we can look back on, but there isn't any real set way that we've decided to kind of memorialize our performance improvement work after they're done. The middle one, maybe you have some notes and some templates that you use. Maybe there's a plan in place that, okay, it's the leader of the performance improvement project that's responsible for kind of keeping that final file together so that not everybody has notes all over the place. And that doing great would really be, you have a template, like a short, concise yet specific document that goes over all the points of the performance improvement project, so that when you pull it out, a couple of years from now, you're really able to see what was done. I don't know if you've seen the A3 forms, but maybe you have something like an A3 form for your QAPI projects.
Yeah, Jane, this maybe would be a good time to remind people that the CMS QAPI tools on the CMS website, there's a good form there to help you. So, and there's other things that might help with some of these other areas.
Yeah, there's some good templates out there that people can use, because this is a challenging thing to do. The next one, for every performance improvement project, we use measurement to determine if changes to systems and processes have been effective. We utilize both process measure and outcome measures to assess impact on resident care and quality of life. For example, if making a change, we measure whether the change has actually occurred and also whether it has had the desired impact on residents. So, again, the not started would be, we really don't do a lot of measurements. We put changes in place. We maybe have the intent of measuring, but it doesn't always happen because we get distracted and do something else, or we don't really know how to do it, don't have time to do it. On our way would be, we do some measures. We maybe observe to see if the change was actually implemented, but maybe don't have a way to really look all the way out to see, did it actually have an outcome? Did the outcome actually have the intent we wanted on our residents? And then the doing great is we really do articulate for each of our performance improvement projects that we have measures of process and measures of outcome. We have goals and we have thresholds assigned to them so that we know whether it's both been implemented in the way we intended and it's having the outcome that we intended. Because sometimes you can implement a process and it doesn't have the outcome. Sometimes you can get the outcome and it maybe wasn't even your process that made the difference. So you want to know what's happening there. The next one is our organization uses a structured process for identifying underlying causes of problems, such as root cause analysis. And so this one, everyone probably says, well, gosh, we do root cause analysis. But what really is getting at is, how is that process really happening in your organization? So kind of that started is, maybe the leadership kind of does the RCA, figures out what's happened, and says this is what we're going to do. It doesn't necessarily bring a team together, but it's done, kind of the leadership kind of does that retrospective review. On our way would be you have a team that gets together to do the RCA. You really try to ask why, get into those underlying processes. And then that doing great would be we really have a process in place, number one, so that we have an algorithm so we know right away when something happens, should this go to an RCA. And so we can work through that algorithm quickly, get our RCA started. We have a process of determining who is on that RCA team and when that team is going to meet, what's the process that team's going to use. We have a facilitator for RCA teams. So really have a good consistent RCA process in place. We're on the home stretch here, last page. Okay, when using root cause analysis to investigate an event or a problem, our organization identifies system and process breakdowns and avoids focus on individual performance. For example, if an error occurs, we focus on the process and look for what allowed the error to occur in order to prevent the same situation from happening with another caregiver and another resident. This is kind of hearkening back onto that previous question, again getting at the just culture piece. So again, for this would be, really we rely a lot on discipline. And when we're doing a root cause analysis, we, discipline and educate those folks that were involved, make sure everybody understands the policy and procedure, tell them to be very careful to make sure the policy and procedure is followed the way it's expected, but we don't really dive into the process. On our way would be, again, acknowledging that we may need to make a change in the process, but again, making sure everybody knows the policy and procedure and make sure that you're very, very careful to follow that. And then doing great would be we really take that just culture algorithm approach of how do we tease out, what was going on in the process, how did the people how does this impact individual behavior, and what do we really need to do both for that individual, whether it be counseling, consoling, supporting, and then also with our process. And the next one. When systems and process breakdowns have been identified, we consistently link corrective actions with the system and process breakdown, rather than having our default action focus on training, education, or asking caregivers to be more careful or remember a step. We look for ways to assure that change can be sustained. For example, if a policy or procedure was not followed due to distraction or lack of caregivers, the corrective action focuses on eliminating distraction or making changes to staffing levels. So again, the knock started, education, training would be the mainstay of our corrective actions. Making sure people are aware how important this is and that they need to be very careful. On our way would be what I like to call implementing solutions. We listen to the RCA and we've already decided, this is what we need to fix it. And instead of saying, okay, we need to treat this as a performance improvement project, we kind of know now what happened, but we have to do our testing. We have to decide, okay, just because we have an idea, if this is going to make a change, we have to test that out and see if our idea is actually correct. So we see a lot of we're going to implement a solution. And then the doing great would be, really we treat our corrective action as a performance improvement project where we make a small test of change, we look to see if that made a difference, we really do that incremental approach to our corrective actions, and education and training are really just an adjunct to make sure people, if we do make a change to the process, that people are aware and they're comfortable with it and know what to do. Next one. When corrective actions have been identified, our organization puts both process and outcome measures in place in order to determine if the change is happening as expected and that the change has resulted in the desired impact to resident care. For example, when making a change to care practices around fall prevention, there is a measure looking at whether the change is being carried out and a measure looking at the impact on the fall rate. So again, it's getting at those process and outcome measures. So not started would be, we just look to see if the change is put in place, not necessarily if that has worked. On our way would be maybe we have process measure but not outcome measure, and outcome measure maybe a process measure, so we're not using both consistently. And then doing great would be, really we again develop process and outcome measures for all of our work that we're doing. We may even look at what we call balancing measures to make sure that our change hasn't had an adverse effect on some other process within our organization. And the last one. When an intervention has been put in place and determined to be successful, our organization measures whether the change has been sustained. For example, if a change is made to the process of medication administration, there is a plan to measure both whether the change is in place and having the desired impact. So this is commonly at that 6 to 12 months. Again, not started would be, just assuming that good ideas are going to stick, and we don't have time to do a lot of long-term measurement. On our way would be, maybe we're going to observe this for a few weeks or maybe over the course of the next month. And then doing great would be, we have a clear sustainment strategy. Maybe there's even a new, team that takes over that's really part of sustaining change within your organization. Maybe it's the current team that really keeps on and looks at that over the course of time.
Okay, Jane, thanks. That was wonderful. We don't have a lot of time, but we have a few minutes if there happens to be any questions. Laura, can you remind everyone how to get into queue if anyone has any questions?
Certainly. The floor is now open for questions. If you do have a question, please press the number 7 or the letter Q on your telephone keypad. Again, that is the number 7 or the letter Q on your telephone keypad. Please hold while we wait for the first question. Our first question comes from Patricia. Patricia, please go ahead.
Hi, I was hoping the presenter could just repeat the phrase. I thought it was so nice, but I didn't get it all. What the piano teacher said.
Oh, yes. She always says, slow practice makes fast progress.
Oh, see, and I didn't write it down correct. Okay. Yeah. Thank you.
And I really think about that when I think of that N of 1, because a lot of times people say, well, I don't want to do it. This takes so long. I want to put something in place. But if you take the time to do those small tests of change, you find that you make improvement much faster. So it always just reminds me of the slow practice makes fast progress.
Very good. Now, was this taped for someone else to watch it later or listen later?
Yes, it is recorded, and it'll be on our website within a week or two.
At the Superior University, you mean?
At the Lake Superior Quality Innovation Network. It will be there.
Very good, because it was an awful lot to try to write down.
Oh, right. I know, it's a lot to get in an hour.
And what state are you from?
Michigan.
Okay. So I'm sure that Kathleen will send out that link when it's available.
Very good.
Okay. I also want to say while we're waiting for questions, I want to remind everyone that what we're going to do now is we're going to send evaluations to everyone that participated in the webinar today, and it's really important that you complete that because we were hoping, what we want to know is which teams really did complete this self-assessment during the webinar, and we really do need that information. So it's a very short questionnaire that we'll be sending out after this, and if you don't fill it out, we'll be giving you a call, so you might as well fill it out because this is kind of new for us too, so we want to see how it worked out.
Yeah, this is the first time we've done a real working webinar, so.
Yeah, so if you have any suggestions too, we'd love to hear those. Laura, is there anyone else in queue?
At this moment, it appears there are no further questions.
Okay. Then I think our time is about good. We just finished perfect. This does complete the webinar, and as I said earlier, it will be recorded. It will be available on the Lake Superior QIN website within a week or two, and I'm sure your lead for your state will let you know when it is available and give you that link. Everyone, have a wonderful day, and thank you for participating. This now concludes the webinar.
Thank you. This does conclude today's teleconference. We thank you for your participation, and you may disconnect your line at this time.